So I'm going to start with just a few housekeeping notes and give an introduction to our speaker today, and then turn it over to him. And there is a chat and a Q&A box that feel free to type in your questions there. And at the end of the presentation, we'll address everyone's questions. So welcome to the webinar, Physical Therapy and the Opioid Crisis, presented by Beau Saunier. This free educational event is brought to you by the Louisiana Department of Health, Office of Behavioral Health, Acadian Area Human Service District, and Women's Foundation. The purpose of the Community Opioid Symposium is to increase awareness and education for prevention and treatment of opioid use, misuse, and abuse. For information on future presentations, visit womensfoundation.com/COS. This session is accredited for 1 hour for social workers, licensed professional counselors, ADRA, and AMA PRA Category 1 credits. Full participation of this presentation is required to receive credit, and you'll be monitored throughout the session. After the event, you'll receive an email from Women's Foundation with detailed instructions on how to claim your credits and access your certificates. If you are listening in by phone, please email Janie at womensfoundation.com the phone number you used to dial in with in your first and last name. Beau Saunier, our speaker, has no financial disclosures. Beau earned his doctorate of physical therapy from the University of St. Augustine in 2015, and he earned a Bachelor of Science degree from the University of Louisiana, Lafayette in 2012. Beau is currently a member of the American Physical Therapy Association and the Louisiana Physical Therapy Association. He recently completed a fellowship program with the American Academy of Orthopedic Manual Physical Therapy. This is the highest level of education orthopedic manual physical therapy that consists of 2.5 years of postgraduate training and 440 hours of one-on-one fellowship training. Beau completed this in December of 2020. So welcome, Beau. We are turning it over to you.
Awesome. Thank you all for having me. First of all, welcome everybody to the webinar here. We're going to talk about how physical therapy can help with opioid, the crisis that's going on, and obviously opioid dependence. One thing that we see, at least in our field, is that opioid use and abuse is kind of the result. But in our field, acute and chronic pain tends to be the cause. So the result will be opioid use, but the cause will be acute and more often chronic pain. And so that's what we're going to talk about today. There's been a lot of research done over the last several years by some great physical therapists that have really dove in, done a deep dive on what causes pain and how different people respond to pain, because it is more than just something that hurts. There's a bevy of different assets or aspects of it and arenas of it. So first of all, let's see here, just a little bit more about my company. I'm a physical therapist at Precision Rehabilitation. We have 4 locations. We have one here down in Abbeville, one in Broussard, and 2 in Lafayette. So I'm currently at our College Slim location, but I typically work between our College Slim location and our Broussard location. And as Ashley said, I'm not being paid any sort of royalties or salaried by the Women's Foundation, Acadiana Area Human Services District, or the Department of Health. Our objectives for today are to, upon completion of this activity, participants will be able to describe the causes of pain. They'll be able to know what makes people susceptible to chronic pain, and they'll understand the role that we as physical therapists can play in helping people overcome acute and chronic pain issues, and thus we hope would decrease the amount of opioid use and abuse in their lifetime. So Ashley gave a great introduction to me. I'm always honored to hear that kind of stuff. But at the end of the day, I'm just a good old boy from Delcombe, Louisiana, down in Vermilion Parish. I graduated from Vermilion Catholic High School out there, and then, as Ashley alluded to, went to UL right here in town for my kinesiology exercise science degree, and then St. Augustine. And then most recently, I finished my fellowship in orthopedics and manual therapy. And most recently, over the last year or so, I've been working with a team to develop an orthopedic and manual physical therapy residency program it's working on accreditation now through the APTA. So basically, if anybody graduates from PT school and they would like to specialize in orthopedics, kind of like I do, they will put them through the residency program and they get direct mentorship from us, and then they can grow in that path, and then eventually move on to a fellowship program should they choose to. So that's a little bit about me. So what is pain? As I alluded to, pain is an experience. There's a lot of different aspects that go into pain, but the Webster's Dictionary defines it as a localized or generalized unpleasant bodily sensation. It can cause discomfort and emotional distress, and typically results from a bodily disorder, such as an injury. That is, the textbook definition. But the last definition here, B, is a mental or emotional distress or suffering. So pain can be like I smashed my hand, I busted my toe on the couch, on the corner of a couch. We all know what that feels like. But on a more serious note, some of us may have experienced a mental or emotional distress. We all can think of when we lost a loved one, if we may have gone through a divorce or lost a pet or something of that causes emotional distress and suffering. And that kind of ties into our talk today about chronic and acute pain. Your brain builds past experiences. I know for me, my dad passed away about 5 years ago. And when I think about that, there's a little bit of that still is there. And you think it brings back a little bit of that emotional feelings that you felt that day. And I feel like if any of you have experienced anything of that sort, hopefully you haven't, but you know what I'm talking about. Anytime you think about that, it brings back, a little bit of those memories. And so pain is kind of one of those things that just, it's complex. It's not as simple as people think it is. And so we're going to talk a lot more about that as we're going through. So now, what is chronic pain? Is it just pain that you've had over a long period of time? Or is there more to it? And as I said, there's been a lot more to it. So the Cleveland Clinic defines pain as pain that's ongoing any longer than 6 months. That's kind of the mechanical definition of chronic pain. It can continue even after an injury has gone away. You get in a car accident. I've had patients talk about, I got in a car accident in 2005, and I'm still having issues from it. And if you work in this kind of field, you may have heard that before. And pain signals can remain active in the nervous system for weeks, months, or years. And also, as we talked about, there's the emotional and mental component to it. So people can suffer from chronic pain even if they've never had a past injury or any apparent body damage. And that's something that a lot of research has done a deep dive into to try and understand, why do people have this pain? What causes that to happen? And chronic pain is very prevalent. The CDC in 2019 did a study that found that chronic pain is prevalent in 20.4% of people. So if you look at the population of the United States, 330 million or so, I got that stat on Sunday or something, so there may be some babies born or something like that, so this number might not be accurate, but somewhere around there, 330 million or so, 20% of that is 66 million people. So there are 66 million people just in the United States that have chronic pain and live with chronic pain. Now, in addition to that, you may be thinking, that sounds expensive, and you're right, it is. Chronic pain is associated with an annual cost conservatively estimated at $560 to $635 billion with a B dollars per year, annual cost. And if you break that down further, and you do research on low back pain and chronic low back pain alone, costs $100 billion by itself. Chronic back pain is something that we see more than anything else, and that by itself costs $100 billion. That's not even taking into account all the other issues that we've had. This is all the other body parts that could be painful. And we've looked, and this is taken into account lost time wages, prescriptions, surgeries, other medical bills that you encounter when you have pain. So the stuff adds up, and that's a huge number. And so when you're talking about chronic pain leading to opioid dependence, you can also think to yourself, that sounds pretty deadly. And you would also be right with that. From 1999 to 2014, 165,000 people died from overdose related to prescription opioids in the United States alone. And in 2017 or 2016 alone, there were 17,087 prescription opioid overdose deaths. So that's what led there to be, in 2017, there to be declared an opioid crisis or an opioid epidemic in this country. I mean, that's a lot of people that died from something that, from prescription opioids. And that's a shocking statistic to look at between this one and the previous one about how many lives are affected and how much that costs and obviously the ultimate effects that come from that. It's shocking. But as we're going through, we're going to talk about acute pain and chronic pain because they are very different. And the way that the brain perceives them is very different. So first, what is, acute pain? So I got some silly little things here, but acute pain is what we call peripheral sensitization. So it's something that affects the periphery. So if you think about your hands and feet being the peripheral parts of your body, just think about it in that sense, and it'll make it kind of easier. When there's tissue damage, the action potential, like a signal basically, flows to your dorsal horn. There's A and C fibers that bring that, that transmit that from your hand, let's say, to your brain, to your dorsal horn in the spinal cord. And the message that is sent does not, it only says danger. It does not say pain. So the spinal cord and the brain must take all of this information and create a meaningful experience from it. And you think about, when you're a child, when you're a baby, you don't know that fire's hot, ice is cold. If you see a pot on the stove that's with boiling water and you look at it and you go to reach it, one of two things is going to happen. You're going to burn your hand, and you're going to find out the hard way that that's hot, or your mom or dad's going to kind of smack you away and be like, no, that's hot, don't touch that. And that creates a meaningful experience for you. And that may or may not include pain. So if your mom smacks you away, like, hey, don't touch that. No, it's okay. That's danger. That's a danger signal to me. I don't want to touch the hot thing. Or I just burned my hand. That hurts. That's painful. I don't want to ever do that again. So how you respond to these things is what creates these experiences in your brain. So the dorsal horn is where is the main location where the pain is modulated and where it decides whether it wants to send it up the chain to your central nervous system, to your brain, for interpretation. And so they call that the gate control theory. Basically, you're going to feel a ton of sensations throughout your day, and not all of them are danger or pain or anything of that sort. So it's up to your dorsal horn to decide whether or not it's going to be transmitted up the chain. So with that being said, your nervous system is highly adaptable and it'll accommodate to most of the demands that are given to you. So all of this happens so quickly. If you put your hand on a hot stove or on a hot pot, you're not just sitting there holding it, you're going to jump back immediately. So all of this happens so quickly. But whenever you have impulses from inflamed, scarred, weak, acidic, that keeps tissues that keep coming to the dorsal horn, it increases the amount of excitatory chemicals. So let's say you do burn your hand. So before, if you have intact skin, you could do this and it doesn't hurt. But if you have a burn on this hand and you're moving it, you're going to feel, that hurts. So you're going to naturally want to guard it. So you're getting impulses from inflamed, damaged tissue. So it's causing you to want to protect that naturally and let it heal. Because if you just keep doing this, it's going to keep opening and it's never going to heal. So this really acts as a protective mechanism for you so that you don't have further damage and things won't turn into a chronic issue. So like it says here, in the short term, danger message neurons increases the sensitivity to incoming excitatory chemicals. So this leads to hyperalgesia, which basically things that used to hurt now hurt more, but also allodynia, which is things that didn't hurt now hurt. So like I said before, it didn't hurt for you to do this. Now you have a burn on this hand, it hurts pretty bad to do that, or it hurts bad to touch it. So you have that allodynia now. So your brain is like, oh crap, that's hurt. Let's not touch that. Let's not move that. Let's protect that. So both of those terms just mean a temporary increase in sensitivity to a stimulus. So what what am I talking about here? There's a lot of different things that people, like, what do you mean these signals? I'm talking about signals and transmitters and all this stuff like this. But at the end of the day, everyone has a pattern in their brain that creates a perception of pain. And we call that a neurotag. And neurotags are just a built-in matrix of neurons that get activated and produce pain. But if you think about it, we have neurotags that are wired. We're talking about pain right now, but there's neurotags for all kinds of things. You think about, you hear a certain song and you think about, oh, wow, that reminds me of, driving around with my buddies in high school, driving on a country road, or you smell a certain smell and you're like, oh, that reminds me of my grandma's house. It smells like, I don't know, baked bread, homemade bread, or something like that. And you have neurotags that trigger certain memories in your brain. But you also have neurotags that are for pain. So it's genetically determined and influenced by your experiences, by stress, by cognitive processes, and by sensory input. So that's what builds these, quote, neurotags in your brain, specifically for pain. It's all based on things that you've experienced. And if you listen, I have a reference at the end of the PowerPoint here. There's a guy, Lorimer Moseley, and he's one of the PTs that did a lot of the research for chronic pain. And he tells a story about, I was walking down through the woods. I felt something brush my leg, didn't think anything of it, was walking down to the lake, dove in the lake, came out and passed out, and almost died because a snake bit me. And so, but at the time he didn't have that past experience, so he just brushed it off as the branch scratched him or something of the sort. However, later on he recovers, obviously, and later on he is going down kind of the same trail, and he felt something brush him and he freaks out and ran. But then he looks down and it was just a little branch that had scratched him. So because he had that previous experience, it built a neurotag for his brain for that specific moment, and basically gave him like a fight or flight response. And he was like, oh God, I gotta go. I gotta get out of here. There's another snake. But in reality, it was just a branch. So what you experience in your past can determine how you perceive pain. And then as we're going forward, we're gonna talk more about how chronic pain is experienced, and that's a big part of it. So in summary, acute pain means that more nociceptors are added and there's increased responsiveness to the nociceptive receptors. It's called primary or peripheral analgesia, primary analgesia or peripheral sensitization. And it's a local phenomenon. It's something that is a protective action by the body and prevents further use to prevent further damage. Like I said, your body, if you have that burn, your body's not going to want to use that hand. It's kind of one of those things like whenever you cut your thumb or something, or like I said, burn your hand, you're like, I didn't realize how much I used that body part until it's injured. Like you feel like you bump it on everything. And it's because your body is sending those protective signals to your brain over and over and over again, just to prevent that further damage to that tissue that's injured and to allow for that normal process to happen. And again, like I said earlier, this happens in a matter of like a blink of an eye, right? You're not sitting there with your hand on a hot pot for 10 minutes, unless there's something going on. It's gonna get sent, processed, and sent, and the reception is sent back, and you pull your hand off as quickly as that. So it happens in milliseconds. So that's basically the summary of acute pain. So now I want to move into chronic pain, and a lot of people will experience this. You see them walking around, and like this guy on the left here, he's smiled, he's focused, smiling, he's focused, but he feels brain fog, fatigue, widespread pain, cramping, shooting. There's a lot of parts, a lot of different things and secondary effects that chronic pain has on the body. And so we're going to get into some of that and why some of that happens. So chronic pain is also known as central sensitization. So acute pain was peripheral sensitization. Chronic pain is central sensitization. Central sensitization is the hallmark of chronic pain. And central sensitization is defined as the augmentation of the responsiveness of the central neurons, so of the dorsal horn and of those parts of the brain. So in contrast to peripheral sensitization, there's just those increased responsiveness, increased sensitivity of the peripheral transmitters, the transmitters on the outside. There, with chronic pain, there's actual functional change to the central nervous system in terms of the dorsal horn and the brain. So it's responsible for some of these mechanisms and the neurophysiologic mechanisms, and it makes chronic pain much different than acute pain. When we see someone in the clinic and they hurt their back last week, it's much different than having someone who's had back pain for 20 years. You know, I've had people that have come in the next day after throwing their back out or what have you. And it's a much different process than I had a guy recently I always think about. And I asked him how long ago that he hurt his back. And he said 1965. I was like, okay, well, your pain is older than my mom. So it's going to take us a little while to get this feeling better. But we worked together. It took us a while, but it was a lot of work, a lot of education, and he got better. And he did well. So they're two very different mechanisms, and you need to understand as a practitioner how those two mechanisms operate. So at the spinal cord level, sensitivity enhancing chemicals swamp the synapse, and there's neurons that can go sprouting. So in this example, like we said, the central nervous system is affected. So you're getting danger signals and you're getting all these signals from all over, but the actual receptor is damaged, is short-circuited almost. So neurons that don't even carry danger messages can be interpreted by the central nervous system and by the dorsal horn as dangerous. So a lot of what we'll see in chronic pain and people who have had chronic pain for many, many years, they'll start to have, just light touch will be painful. Changes in temperature, they'll have sensitivity to hot or cold. They'll walk in with sunglasses on because light sensitivity, light will send a danger message to their brain. And so their brain is, like I said, being tricked and it's operating on faulty information. So this is very interesting to see in the clinic in real time. Sensitization can also be characterized by temporal summation. So like we said, the different sensations like changes in temperature, light touch, yada, yada, can cause pain, but also the constant pain or the constant, touching or what have you. So, it's like the thing that I liken it to is, if I sit here and I touch you and I let go, you're not going to have anything. But temporal summation is kind of like if I'm sitting here like this, if you don't punch me in the face before too long, after a while, it's going to start to hurt. And so that's kind of what temporal summation or wind up pain is. It further sensitizes the system. So as a practitioner, we have to be very careful if someone's had pain for a long time on how much we do, because too much of a good thing isn't always a good thing. So if we're, doing a lot of different hands-on skills, we do a lot of hands-on manual therapy with them. If we do a little bit too much of that, it could actually set them back a little bit. So we have to find that delicate balance between too much and not enough. The amount of pain experienced by the patient does not necessarily relate to the amount of tissue damage present. I've had patients that have come in and they've had, they have just arthritis in their spine, which we'll get to later is very common. And they've had, 10 out of 10 pain. I've had patients with full-blown herniated discs that have very little pain. And it's all about how the brain perceives it. So simply put, if there's no pain, it means that these changes in your tissues are not perceived by your brain as a threat. So, there's very different things that occur. Like we said, if there's, an actual injury, if you have just had things over like chronic issues over time, if you've had a past experience that is negative, it'll change how you experience pain. The brain decides whether or not something hurts 100% of the time, with no exceptions. So they did a study, I read a study recently or a couple of years ago that talked about the difference between demolition derby drivers and their risk of neck pain or chronic neck pain versus someone who gets in a motor vehicle accident. You think about, even if you're thinking in the terms of demolition derby, you think about when you go to the fair and you're on the little bumper cars, right? I mean, you're trying to hit people with your car, but it's fun. You're laughing, you're joking, you're pointing at your friends, you know, if they're on there with you, and it's fun. If anything happens with demolition derby, this is my job. I'm supposed to do this, and it's not a big deal. However, it's just kind of more mechanical, or in the bumper car aspect, it's more fun. But if you think about a motor vehicle accident, there's a lot of different things that come along with that. There's you know, oh my God, you know, I hit this person. Are they okay? Did I hurt them? Did they have a child in the car that could be injured? Now they don't have a car. I don't have a car. How am I going to get to work? I'm not telling my husband or wife to bring me to work. I'm going to have to get a rental car. We got to file a claim. There's a lot of different things that go into this. You can imagine where with a motor vehicle accident, they actually had a higher risk of developing chronic neck pain more than someone who's in a demolition derby. And demolition derby drivers get into roughly, I believe the statistic was 7,000 accidents over the course of their career. 7,000. People may get into one or two in their whole lifetime. But because of all of the other things and all of the emotional and mental experiences that occur with a motor vehicle accident, they're at a higher risk of getting chronic neck pain. So it just kind of shows how much that has to do, even more so than the actual structure affected. So wait, pain can really occur with or without injury? Sure. This is another study that I read. They took 3,110 people and they did MRIs on them. And this was done in 2014. And they looked at the prevalence of all of these issues: disc degeneration, bulging disc, protrusion, annular fissure, facet degeneration, spondylolisthesis. Disc degeneration is basically just arthritis, naturally occurring arthritis in the lumbar spine. And by age 30, if you look at the follow the blue line, there's a 50% chance that they have arthritis. But all of these people were asymptomatic, aka they didn't have any pain at all. You look at this bulge at age 30. I'm 30, that's why I'm pointing this out. So at 30 years old, disc bulge, 40%. And then, you know, going down the line to disc protrusion, annular fissure, you're looking at 20-30%. There's a 20-30% that me right now sitting here talking to you, I have any of these conditions. There's a 50-50 shot that I have arthritis in my spine. I don't have any back pain, knock on wood. Nothing hurts right now. And then as you can see, as you get older, when you're up to 70 years old, you have 90% chance you have arthritis in your spine. You have disc degeneration in your spine, but doesn't mean you have to have pain. So relaying that information to our patients is paramount. And it shows that just because you have an issue doesn't mean that you have to hurt. And we try to do a really good job of educating our patients on that. So this is a very interesting study. This is something that I bring up all the time. I'll have patients come in and they'll talk about how they've got arthritis and this and this and that. I'm like, at this point, it's kind of like, well, you're 70. It'd be a little odder if you didn't have arthritis. But at the end of the day, it doesn't mean you have to hurt. So we get into that. So how does the brain decide? How does the brain decide what hurts and what doesn't? So there's a bevy of different things that you'll experience. So the brain concludes if something hurts based on if there's credible evidence of danger or if there's credible evidence of safety. And so we'll talk about danger in me. We call these danger in me or DIMS. So let's say you hurt your back and you go to a practitioner and like, nothing's wrong with you. Your pain's probably just in your head or it's not real. That's not going to make you feel very good about your prognosis or about your recovery. Believing that you may end up in a wheelchair. You're like, oh, well, so-and-so's grandmother had back pain and now they can't even walk and they're in a wheelchair. Like, that's horrifying. And then, like I said earlier, receiving a diagnosis that sounds really bad, but not actually knowing exactly what it means. So people will hear they have degenerative disc disease and they think that their spine is just collapsing. When in reality, that's just another term for arthritis. And it's like we showed in the earlier slide, it's very normal after a certain age. And the last thing would be going to the same place where you injured your body. So if you get in a car accident and you pass by that intersection or wherever where that person ran that red light and T-boned you, it's going to bring back some of those same memories to you. So it's very important to understand and to educate clients of ours or patients of ours on what their symptoms mean, what their injury means, and how we're going to treat them. So this buys into the safety in me. So being aware, this is the things that are positive. So being aware of a scientifically proven path to recovery and making an appointment to see a good health professional. So this is the difference between if you're talking to one of your buddies, you hurt your back, you talk to one of your buddies and they're like, oh man, well, you know, I hurt my back 10 years ago and I've had 3 back surgeries since, and I can't do anything like I used to do. That's going to sound a lot different in someone's brain as compared to, I hurt my back. I saw this guy, Beau, or whomever you want to see, and now he helped my back out, and now I'm able to do everything that I wanted to do. And so that is going to sound much different in your recovery, because then you're like, if you start going down one path, you're like, oh my God, I'm going to be crippled. There's nothing I can do. Whereas if you know there's a way out, if you know that you're not the only person in the situation, then you're going to be a lot better off. And then obviously there's local anesthetic injections that help as well. And then also having the loving support of someone. If you have a partner or a friend who's there for you that can listen to your things, because they always say, you know, the fear of the unknown is worse than the known. So you always think about, I liken this to, you know, if you're in the woods, right? You're walking around the woods, it's daytime, you can see everything, you know what's around you. But if you think about the horror movies and, you know, there's a killer on the loose, let's go see what that noise was in the woods. And they're walking around with their flashlight, and that's all they can see is what's right in front of them. And then they hear a twig snap and they freak out. You know, that plays into that danger in me that they may experience as they're walking around. So obviously you want to have, if you have more safety in me, then your brain is less likely to determine that this is going to be a painful issue or a chronically painful issue. So next we're going to get into how can physical therapists help with chronic pain. So to understand that, we need to understand a theory called smudging. Yes, smudging, it's kind of a silly term, but it makes sense. So all parts of your brain, all body parts are represented in your brain by what's called the somatosensory homunculus. So it resembles a person, and in healthy people, the map is very clear and it's well defined and sharply focused. So your brain is able to get clear signals from your hands to your face, to your legs, to your back. It's all sharp, everything's moving like it should. And so the more clear everything is, the less likely you are to have pain. However, if someone has CRPS, which is complex regional pain syndrome, it typically occurs after a crush injury. It's like a severe hypersensitivity, or if they have chronic low back pain, that map can change and become very blurry. And this is called smudging. So the longer the pain persists, the more advanced the changes in the brain become. And so, like I said, your brain naturally wants to protect you and wants to look out for you. And so it makes that body part difficult to use. So it's going to protect your back. It's going to protect your hands. And it's not going to allow you to do that. Whenever we're in the clinic and we're trying to teach patients proper movement and different things, we have to really emphasize a lot of this, because like they won't know where their body is in space. Their brain has been protecting them for so long that they won't understand how to bring their pelvis back or how to, you know, move their head into like a nod. They can't send that signal properly. So we have to re-educate them on that over and over and over again, to where it helps to sharpen up that image and make those signals more clear, so that their brain can better process what's going on exactly with that body part. So this is kind of a little image of what the somatosensory homunculus looks like. There's a motor side, which is just movement, and then a somatic side, so a sensory side here on the right-hand side. That's basically what it looks like. Every body part has a different part of the brain. So just to give you a visual of that. And like I said here, the more the body part is out of focus, the more pain is present. So it's again, going back to like the in the woods analogy, there's a murder on the loose, or, like in their case, like I hurt my back once or several times. And so now everything is kind of out of focus. I'm scared. I don't know. The brain is scared, doesn't know what's going to happen if you do certain things. So it proceeds very cautiously. And even the most interesting thing about this is, even though a body part may no longer be present, so let's say they had an amputation, they can still feel pain. If any of you have worked with anybody who has had an amputation, they have what's called phantom pain. And so it's a very interesting thing. And that's because that part of the homunculus doesn't just go away. It kind of integrates itself into the adjacent parts around it. So they could still feel pain for months or years or forever after having an amputation. Smudging can also occur with the chronic use of opioid pain medication. So your brain is going to naturally kind of smudge that image a little bit, and then they start taking pain medication to try and alleviate the pain. So it kind of, you've heard of people say it almost puts a Band-Aid over it. So it kind of blurs the sensation from that section of the body. So then the brain is not getting proper imaging or images from the brain, or proper sensation from the brain. And so you can see where that would cause the smudging effect to occur. So how do you treat smudging? So you have movement, but more specifically, proper movement. And I say this because a lot of people that we see here in the clinic, unless they get hit by a truck, or they fall off a ladder, or something crazy happens, unless they have that big traumatic event, it's not just that one macro trauma. More often than not, people have what we call repeated micro trauma. So improper movements over a long period of time. And we'll hear patients talk about, man, I don't know, I bent over to grab a towel when I got out of the shower, and after that, my back went out. And so I don't know what to do. I guess I'm getting old. I can't bend over and pick things up like I used to. But what we educate them on is, actually, you're moving improperly at this joint. Certain things you've probably been doing that for 20 years, and bending over to reach that towel was kind of the straw that broke the camel's back, so to speak. And so as physical therapists, we are movement specialists. And like I said, most people's pain comes from improper movement over a long period of time. Improper posturing, improper walking. I hurt my ankle, so now I'm walking a little differently to compensate. So now I hurt my back or my hip on the other side. And so that's the things that we are trained, especially at the fellowship level. We are trained to identify improper movement, and we know how to fix it, or how to help you manage it and get it moving properly. So we understand, as physical therapists, we understand with all the research coming out and everything, that chronic pain is a process. There's not just the physical limitations, there's also the mental and the emotional components of this. And we understand that. But with PTs, we sit here and we listen to you, and your goals become our goals. And so as we're looking at stuff and we're doing our subjective history at the start of our sessions, some practitioners will look at you and they'll say, okay, well, what if you had to rate your pain on a scale of 0 to 10? 0 is no pain at all, and 10 is we need to go to the hospital. How would you rate your pain? And you look at me and you say, 8 out of 10. Okay, they mark that down and they move on. But for us, especially for me, I like to take things a step further. So I'm like, I'm an 8 out of 10 pain. I'm like, okay, that's a lot. I'm like, yeah. Like, well, what kind of things has this stopped you from doing? What kind of things in your daily life has your back pain limited you from being able to achieve to the level that you want to? So I had a guy a couple weeks ago, and I asked him that question, and he said, well, I really like to play golf. I haven't been able to play golf in 6 months because of my back pain. And I'm like, well, I look at him and I say, well, sounds like you don't have a back problem. You have a golf problem, right? And so a golf problem sounds a lot cooler than a back problem, right? And so if we integrate your goals and whatever it is that you want to go to, and trust me, we've heard, right when I think I've heard it all, somebody tells me something else, and that shocks me. But I feel like I've heard a lot of things. There's nothing too crazy. Some people like to be able to sit and read. Some people like to be able to sew. Some people are cross stitch. Some people like to be able to play golf. And so we keep those goals in mind as we're going forward, and we give you things that are going to help you work towards that goal. Like I said, it's no longer a back problem. It's a golf problem. It's a tennis problem. It's a weightlifting problem. And we take that and we build on that. And so we have all the advanced training in anatomy and physiology. We are trained to use, in our fellowship, we learn 1,500 manual therapy techniques. And we learn several hundred specific exercises that help to take away that sensitizing movement. And then lastly, we educate patients on what these injuries mean. And we integrate their goals into treatment. So we'll have guys and, they'll come see us and they're feeling better. We're 2, 3, 4 weeks in, they're feeling pretty good. Their pain's, like a 1 or a 2 instead of like an 8 or a 9. And so then I look at them and I'm like, all right, man, well, you said you want to go play some golf, go play, go to the range, go hit your fishing wedge, go hit your approach wedge, go hit your 9, 8, 7, irons that are easier to swing. Just go hit a small bucket, see how it feels. And 9 times out of 10, they ask me, well, what if it hurts? I'm like, well, I would rather it hurt while you're under my care, because then you can come back to me and we can look at, okay, where does it hurt? Go through your motion. What can we change in your plan to make this not so bad? So then as we're going through and as we're working towards discharge, it's like, man, I went play. Used to be I was a 9 out of 10 pain with around the golf. Now I'm at a 4 out of 10. Okay, let's take a look at some things. Let's mobilize this. Let's strengthen this specific thing, and let's go play again next week. Okay, we go play again next week. 2 out of 10 pain. Cool. Let's tweak another couple things here. Let's really get you going, work on that endurance a little bit more, or change something, or get you feeling better, moving in this direction. Okay, now it was barely a 1. It's like, okay, now we got it. Because what I tell people is, if I see you for 6 weeks and your pain goes from 8 or 9 out of 10 to a 0, that's cool. But if you haven't been doing the things that you want to do or achieving any of the goals that you personally want to achieve, then we're not really helping you. Getting someone from, if I look at someone at a reeval and I'd say, you had a 3 out of 5 strength in your quad, and now you have a 4 out of 5 strength in their quad. They're going to look at me and be like, cool, what does that even mean? That's great, And we take those numbers for ourselves. But at the end of the day, it's like, okay, can you go play golf? Can you deadlift without pain? Can you pick up your kid? The most heartbreaking one for me a lot of times is people that have kids or grandkids and they can't even pick up their kids. They can't play with their kids. That's always super heartbreaking to me. So it's like, can you get down on the floor and pick up your kid? Can you do the things that you wanted to do before you had this injury? And that's how I know that you're getting better. And that's how I know that we're on the right track. And if we're not, we're going to change stuff up and we're going to make this happen to get you there. So this is just kind of a little example of what we do. We mobilize here in the middle. We teach you proper movements, proper exercise. And then number one thing for us, we educate. We educate you on your condition, because in my opinion, the more that you know about your condition, the better you're going to be. It's our goal to empower our patients to make lasting changes in their lives. And so if we can make lasting changes in our clients or in our patients, then we can help them deal with their chronic pain and hopefully get them off of whatever opioids, or help be a small part that brings on the change that helps them with their opioid addiction, and just help them live a life. I tell my patients, I love seeing you here in the clinic, but I would rather see you at Rouse's or wherever the local supermarket is, or at the gym, at the golf course. I'd rather see you over there, because that means that you're doing better. Obviously, we have interest in treating people, and we got to get people in the door, but I would much rather see you out living your life, because that to me means that you're on the right track. You're making lifestyle changes and you're feeling better about everything that is going on in your life. And that's what my goal is as PT, and that's what I'm passionate about. So that's really how we achieve things. And if we all work together, then we all get success. So these are 2 of my guys that that I worked with that had great success, and 2 wonderful clients that I'm happy to share, and they're cool with us sharing their experiences. But this is our goal. Our goal is to discharge you to your life and to go on about whatever it is that you want to do. Lady on the left liked to walk, liked to exercise. Guy on the right was a diesel mechanic, liked to get underneath his camper and do a brake job. And I was working with him, and I was like, "How you been feeling?" He goes, "Well, I did a whole brake job on my camper, so I think I'm doing okay." And that's the kind of things that I want to hear from my clients and my patients. So with that, I'll turn it back over to Ashley and Janie and them. Does anybody have any questions for me that they would like to ask before we sign off?
Thank you so much, Beau, for that great presentation.
Thank you.
We do have a few minutes left, a little over 10 minutes. So if anybody has specific questions for Beau, feel free to type in the chat or the Q&A, and we will read them off to Beau. I know in the past, everyone has asked about the PowerPoint slides, so they will be available. Everyone that attended, I will email a PDF of that copy to everyone. Okay, so we have a question. Can you say more about arthritis and the pain control for this condition?
Okay. So like I said, arthritis is something that's very, very common. And in most people, it's more common that they have it more than they don't. Now, as a PT, I can't get rid of your arthritis. I'll say that I'm not God. Right? I can't get rid of your arthritis. But by strengthening the muscles around that arthritic joint, let's say it's the hip or a low back, by strengthening everything around that, and by even mobilizing and stretching out different things, different muscles and different joints, we can help to take pressure off of those arthritic structures. So if someone's got a really painful hip, they got an arthritic hip, a lot of times they have weakness at some of the muscles around that hip. And so we work to strengthen that up to where it takes pressure off. The muscles themselves are able to take the brunt of the force when you're walking around, when you're squatting, when you're running, and they put less pressure on the arthritic structures that you have. So that's kind of how we operate with arthritis for arthritis wise. Like I said, I'll never say that I can take care of someone, that I can get rid of someone's arthritis. It's always going to be there. But if you don't have pain, in my mind, you can still do everything you want to do. So I hope that makes sense, Vivian. If you would like to elaborate any more, I'd be happy to.
We have another question from Ms. K. Do you require imaging before you begin treatment?
I do not. So it is good to have imaging, but we have, and one thing I probably should have brought up is we're trained to identify red flags, and so we have specific questioning and specific testing that we do to identify things that are potentially that could potentially be out of our scope of practice, or that could be dangerous to the patient. For example, if someone has low back pain, we always ask about if they have any urinary retention, they have loss of bowel and bladder control, if they have saddle anesthesia, so if they have numbness and tingling in the area, like if they are sitting on a horse, any recent weight loss. And there's like a bevy of questions that we ask to screen out all of our what we call red flags. At that point, I may refer back, or if they come in direct access to us, like without a physician's referral, I'll say, hey, maybe we should go get a look at this. Maybe go back to your doctor and get a look at this before we start treatment, just to be safe. And I always err on the side of caution, especially if people are starting to talk about different things like I've had blurred vision, slurred speech, I've passed out when I was in my car accident, I lost consciousness. And so we always kind of tend to err on the side of caution with that. But that's kind of how we look at that. But generally, we don't typically require imaging to start care.
Okay, thank you. We have another question from Ms. Jennifer. If someone is addicted to pain medication, do they need to be detoxed before you can work with them?
Not necessarily. I mean, we've seen people with different things at different points in their time with addiction, or that may, and it's not for me even to judge if someone is addicted to pain medication. Like I said, we're just part of the process. If they choose to seek out detox or rehabilitation in that sense, that's on them. If anybody has any resources they'd like to send over to me, I would be more than happy to keep that. And if a patient asks me about it, I'd be more than happy to share that with them. But as far as like me asking them to be detoxed, I don't typically require that, so to say. But yeah.
Another question from Miss Vivian. Are supplements recommended for pain issues?
Vivian, I actually can't give any recommendations on that. People have tried different things and they've told me about, but I really can't give any supplement advice for that, honestly. That's really out of my scope.
Ms. Dawn is asking, is there anything that can be done for plantar fasciitis in physical therapy?
Absolutely. We treat plantar fasciitis a ton, and oh man, that's a whole rabbit hole. But so we treat plantar fasciitis. A lot of times what we'll find is that plantar fasciitis can be actual plantar fascia issue, like on the bottom of the foot. It could also be a nerve issue, which could be coming from the lumbar spine or somewhere down the chain, lumbar spine, hip, knee, ankle, foot. And we do a full assessment of you. We look at you top to bottom, because I don't believe that that an issue is just a foot issue or just a knee issue. We look at the whole chain, and so we tease out whether or not that's actually the plantar fascia issue, or if it's a nerve issue, which is coming from the sciatic nerve, which is a lumbar spine issue. And so if we'll hear people who have plantar fasciitis in both feet, and that's something that we hear a lot. And very rarely is it solely a plantar fascia or a foot issue. Most of the time it's coming from something up the chain. And so we address the whole body and figure out, where is this, what's the cause of the cause, where is this coming from? I hope that makes sense. But yes, we treat plantar fasciitis all day, every day, pretty much. So.
Okay, it looks like no more questions. Last call for questions, either in the chat or Q&A. But I think that's it. So one last thing for everyone that attended, thank you so much for watching the entire event. We will be announcing our Doors Prize winners tomorrow. There was going to be 10 lucky winners. You'll get also an email in the next few days how to receive your certificates, how to download that information, as well as sending the PowerPoint presentation that you just watched today. Our next event that is scheduled for May 17th. You can visit womensfoundation.com/COS to register for that event. If you go back on that page, we will be updating that periodically as we have more events scheduled for our Community Opioid Symposium. Well, thank you so much, Beau, for your presentation. Hopefully we'll have you back soon. And everyone have a great Wednesday. Thank you all so much.
Thank you, everyone.